慧有没有听到我声音？千慧有没有听到我声音？可以听到哈。
对，很清楚。
好，谢谢。
Ladies and gentlemen, welcome to join THQA, JCT, and the ASQUA in Medical Quality Library International Master Webinar. I am Wei Chun Huang. Today, our topic is mentioned about the IT and the patient safety. Next. So I'm Wei Chun Huang, as the chairman of the International Cooperating Community in Taiwan Healthcare Quality Association. Welcome to join this webinar. We were talking about the IT and the patient safety. Next, please. So this webinar is organized by Taiwan Healthcare Quality Association and also Joint Commission of Taiwan. Next, please. And also Asian Society for Quality in Healthcare, ASQUA. So we are welcome our Dr. Ho Chun Wang who have opening.
Good evening, ladies and gentlemen. This is Ha Chun Wang from Taiwan. I'm currently the president of ASQUA and also the CEO of Joint Commission Taiwan. It's my pleasure to have this chance to give this opening talk at this very meaningful event. As you may know, that there are more and more information technology get involved with healthcare. While the IT brings us convenience, efficiency, it comes with some risk to harm the patient's safety. So when we move forward to use more and more IT technology into the patient care and embed it in the medical device, we need to pay more attention to this emerging patient safety issue. So today, we are very happy to have many distinguished speakers from this area to give talks on the IT and the patient safety. So let's start with today's event. I wish the best of the success of this event. Thank you.
Thanks, Dr. President Wang's opening. So next we will invite our president of the Taiwan Healthcare Quality Association, THQA, Professor Shaoyu Zheng for the opening. Professor Zheng, please.
Good evening, everybody. I'm the president of Taiwan Medical Quality Association. I'm from Taiwan. I'm very happy to co-host IT and patients conference, safety conference with the ASQUA for all the healthcare staff, all the members in the Asia, all the world day this evening. I think this is the ongoing healthcare events. The patient safety have come a long way in the past 10 years, especially after implementation of the information technologies have become more important. And how do we achieve the serious patient safety during each every healthcare procedure in the hospital is very important. And now IT in the healthcare become a very important role or tool or system to help to assist all our healthcare staff or the college in the moving to one safety medical practice. I'm very happy to say that we invite two well uh, uh, well-known distinguished guests to share their medical excellent experience from medical fields to bring different new concepts for all us. I hope everyone from online can get satisfactory answer on experience in these two excellent speeches. I wish all enjoy. Thank you.
Thank you so much for President Zheng's opening. Next, please. If you have Q&A, please use this QR code. We will please leave your message at the Slido. Thank you. Next one. Thanks for the organized society and also hospital. Next one. So let's begin our medical library international forum. First, we will introduce the director of quality center in National Taiwan University Hospital, Dr. Shi Chen. Please introduce the first speaker. Thank you.
Okay, thank you, Professor Wang. I'm Dr. Xin Chen from National Taiwan University Hospital of Taiwan. It's my great honor to host this section and introduce our outstanding speakers, Director Eric Wu. Director Eric Wu is currently the Regional Director of the ECRI Emergency Care Research Institute in the Asia Pacific region. He's a certified healthcare risk manager by ASQUA and the CAHO, and has 26 years of experience in healthcare associated issues, including novel technologies and strategy design and the implementation and the risk management. He is also an expert in health technology and associated hazards, prevention and management. Today, he will give us an in-depth speech about the health IT impact on patient safety. Let's welcome Director Wu.
Thank you, Dr. Chen. Can you guys hear me? So
yes, clear.
Yes, clear.
Let me just share the slides.
Yeah. No hurry.
Okay. So let me try share it again. Some technical issue. So I don't have the ability to share the slides here unless I log out and log in again. I have sent a copy of the slides as well earlier. Can somebody pull that presentation out as
Director
well?
Wu, maybe I can share your slide from here.
Okay. Okay, thank you.
And I'm so glad that I could share more about this particular topic. And today I'm going to talk about health IT impacting patient safety. And before I begin, good evening. As part of what we do in ACRI, we have to declare that we have no apparent conflict of interest in the reports that we are presenting for today. So let me just share with you some of the findings we have related to how fast and how many countries has actually adopted health IT in the healthcare system itself. This is an older report in 2016. If any of you would have any updated reports on such statistics, please do contact me. I really like a little bit more update in terms of the numbers itself, and we're working to look out for it as well. So WHO has done a sort of a study, and they have been tracking the diffusion of health IT globally. And here are some of their findings. And you can see within the 5 years of 2010 to 2015, huge spike. There's a real adoption of health IT, and people believe that it brings along good clinical and operation efficiency. It provides effectiveness in how care is actually being delivered in the hospital. And we're not doubting all those things, and we believe those are really the great contributing factor to a lot more of the healthcare facility adopting health IT. And of course, you can see some of the statistics that they found is usually more in the higher income and upper middle class income nation. I think that's very much related to the availability of funding, reimbursement, the wonderful ecosystem to improve standards such as the infrastructure, reimbursement system like I mentioned before, policies as well. Good legal framework that is guiding and governing the adoption itself, and of course the skilled labors that's available in those countries that we talk about. So all in all, you can see that there is a high demand, and it will continue to have a high demand for health IT in healthcare. In this slide, you can see there are some published reports talking about the success of health IT, some of the key satisfactory points that you can look at, such as client satisfaction, treatment and clinical more effective and efficient, good secure data, patient engagement and population management and savings as well. That has been contributed by health IT. In essence, you can see some of the key areas that a lot of people talk about in a lot of the reports that we have actually analyzed. Communication is very key. They say that having health IT has actually improved a lot of their communication effort within the care setting and also within the care protocols and processes as well. So again, a lot of claims about the system reducing medication error. It has also effective adherence to clinical and operational guidelines. When you have built in your process into the system itself, the system usually drives the individual or the care team members to actually adhere to the protocol itself, right? Think tools such as CPOE, clinical decision support tools, those are the ones that a lot have been developed and a lot have been adopted as well. So all in all, a lot of the report says that it has improved treatment safety, quality, and efficiency. So essentially, I want us to actually sit back and take a look at what really are health IT and how it's going on in our healthcare system, what it does for us on a day-to-day as well. So essentially, health IT is driven by data. A lot of those information are inputted into our system itself, whether it's data from the patient information, data from the processes that has been carried out. So those sort of information are actually being stored, and a lot of such information are said to have helped in patient-centric care by leveraging on all the data churned out by decision support tools, looking at the multiple data points itself. So a lot of factors needs to be built into the health IT system, and of course we know it's driven by data, but there's also a lot of systems and algorithms that need to be embedded into the system itself, and therefore with such a system it does benefit and it has provide positive outcome for healthcare providers as well. And we know in order to make sure that we collect and we have the opportunity to gather data and collect all of them, device and sensors are being used a lot, and we have been deploying various kind of devices. We've been deploying various kind of sensors, including variables, real-time monitoring, and other seamless transmission technology as well. And with all this technology and new devices or new sensors that we sort of bring into our healthcare and care setting, we hope that it will allow us to capture more data, and it does. And there's a lot more technology that are actually being built and developed today and are also being introduced. A lot of universities are researching on how to use sensors to collect anatomical data or patient physiologic data and stuff like that. So we see that coming a lot, and when with all these data that are collected, it gets into the system and the algorithm is devised, right? So a lot of scientific factors are being thought of as part of that data point and consideration and criteria. Using a good mathematical formulation, you develop an algorithm, and that's the beautiful thing about using health IT and having a lot of those data itself. And when that algorithm is being used in the clinical setting, it becomes a tool. So here's a simple diagram that I have based on the understanding and the knowledge that I've gathered Over these years, when we were researching on the development of IT in our healthcare environment itself, so data and devices will be actually generated into a system itself, passing through an algorithm, and that algorithm is now then displayed or being used into a clinical supporting tool or devices, and then the users will use those data and information to care for our patient. So then a feedback loop comes back, and that has been always how a simplified version of the process. It looks simple to a lot of the clinical team members. These are something that are very common. You buy a device, you have a device that can do all this for you. It gives you the outcome that you want, and then you use the outcome or the information to care for your patients. Anything go wrong, you feed it back to the technology manufacturers or the IT facility team so that you can get things fixed as well. So simple, right? It's a simple process and a simple flow. But I just want to take you guys to a little bit of a deeper dive so that you have a little bit more appreciation. I know I'm not an IT guy, and a lot of us are not, and some of you guys on this webinar is. But here's what it is: a simplified thoughts to how the framework is actually being created, a framework that is actually being used so that integration can be achieved. And if you can see, these are sample of frameworks that has been created by many people as well, that is being used to create and generate your integration itself. So it's not such a straightforward, and if you look at it literally by itself, it's really not just a straightforward protocol or straightforward direction that we use. So when we adopt a technology itself, it seems simple and easy when we just use the end result and the outcome of the technology. But behind the technology that you are using, there's a lot of work that has been put in place, particularly from the point on how to collect and what to collect in terms of data itself. And this is just a little bit of a sort of thoughts to your mind, and I really like you guys to really think about it. The complexity behind designing this, and a lot of the IT folks would agree with me, involves a lot of factors. The technology itself is just one of it. The software itself is just one of it. The human factors are huge. It's huge. And it becomes very complicated when we also embed your clinical and processes into the system itself. So therefore, understanding a simple framework like that gives us a view that health IT and technology integration together, data and also to help you make clinical decisions are not easy to come by. And because it is complex, and I think a lot of you would agree, it also have inherent risks. And I want to really take you through what are some of those challenges that we see already that has been published through research papers, and what do we talk about. So today I really want to talk about how this beautiful ideas and beautiful concept of using health IT integrating into our care setting poses a certain challenges that we now need to take note of. So let's run through some of the research study that I've reviewed, and we will share with you some of the issues and challenges, a little bit into the deep dive into one or two of the key areas that are commonly being reported as the issues and challenges when we use and adopt health IT. And I hope this will give you an understanding and a view of what is challenging us rather than also the benefit that you get from health IT. So now we are going to look at some of the articles and journals that I've gone through and that has published some of the challenges that I mentioned earlier itself. So you can see from this article itself, it says user error, poor user interface. So this has been a big challenge, and it has been a very big challenge where information are not really transferred properly, and that has caused a lot of wrong decision making to happen in our clinical setting. An example here are clinical errors that has led to medication error as well. And we have this as a good example, and I was reading through one of the cases where the CPOE system clearly indicates what the physician says when you need to administer a medication for a patient itself. But when the dashboard or the interface was open in the nursing information system, where the nurse is in charge, are supposed to retrieve those information and take those instruction from the physician so that she or he can actually administer that particular medicine to the physician. So what has happened was that there's a long list of administration instruction by the physician itself, but what appears in the nursing system was just a portion of those instructions and not the full instruction that was given by the physician itself. Therefore, leading to the nurse making the wrong decision as what they has to do and causing a medication error to a patient and harm as well. So this has actually also happened. The next journal article actually is very interesting. It talks about 9 key short-term challenges. And again, they say short-term, but hopefully it doesn't get prolonged as long-term. So short-term when you can solve all the issues. It becomes long-term when you cannot solve them or you ignore them, right? So let's look at some of the 9 areas, and very nice and interesting article that I read. They found that developing the models, the method, the tools to enable risk management is very difficult. So when users are using a clinical supporting tool or clinical decision-making tool that you have, it looks very seamless. You just click in and you just look at it, what the system tells you that based on the data and analytics, this should be what it is, and this is the outcome. But behind the scene, there's a lot of work that needs to be done so that that model works, and I've talked about that in my earlier slides as well. And they still find it very challenging because too many different protocols that is needed as well, and too many different outcomes that is needed. So that has been a big challenge as well. Designing a standard user interface is number 2. Imagine the interface used in the billing department, the emergency department, your endoscopy room, used in operating theaters or operating rooms, your ward, your different ICUs that you have, all have different interface, including your outpatient setting as well. So it is not easy to use one system and create multiple interface and then designing different sort of information that is required in there, and they still find that very challenging. So number 3 is about safety of software, and I would say just bundle and categorize this safety of software as safety. And you can see in number 3, 7, 8, and 9, there's a lot of talk about how this technology or this softwares and health system that we bring into the hospital has a lot of challenge to make sure that it is safe, right? So we see that a lot. The network issues, the software issues on the interface. And number 7, you look at real-time surveillance in monitoring the performance, on the safety of it, developing a culture and a legal framework. Those are things that are very important. How do we secure health information of a patient itself? Those are important things, right? So other than those safety issues to software and to the system itself, they also found that the implementation method is very difficult. And it is very challenging because of the variation of clinical users that they have. And I think they really need to sit down and consideration of the users itself as well. So developing and implementing a decision support tool which improves safety. So you already have a lot of gold standards and how you do things. And by using a system to develop a tool that improves that can be a very big challenge. And this is one of the articles that I read. So just to continue very quickly as well, we also found that this article interesting. This study took only 2,627 incidents that are related to health IT itself. Found that 97% of the incidents assessed for harm actually has very little harm, right? So 82% of the health IT failure caused no harm. 331, which is 13%, caused low harm, 4% caused moderate harm, and 1% caused severe harm. And let's just pause here a little second. 1% caused severe harm. and 1% is 14 cases. So severe harm can be very bad for our patient, even though it's 14 patients, right? And there is less than 1%, which is 4, that has led to death actually, right? The interesting part from this particular article is that 75% of all these incidents that has been reported can be prevented. We should have prevented this from happening. So this is just an interesting study. And I'd like to take a little bit more deep dive and to understand what are the additional, why is it so difficult and why are we still having a lot of this harm, right? So interesting study that I read through from the US itself. CPOE system that most of us have today, and we use CPOE system to really make sure that we can prescribe and order our medication, both our in and outpatient as well. So in the US, right, so this is in the US and it has led to medication error. So that's the conclusion. CPOE system has actually caused unintended medical errors. In the US, it is the third leading contributor to all medication errors. It is the third leading contributor. CPOE system was designed so that we minimize medication error in prescription, transcribing, dispensing of the particular medication to our patient. However, it is now reported as the third leading contributor to medication error. So take note of that. So other additional studies that has a long record is the next one. We have 18 adverse events that are actually related to electronic health record, resulting in 7 deaths, right? A survey done, this is just a survey done in 2019, they found that 1 in 5 patients noticed, and this is a patient notice, that there is an error in their medical record, and 9% of that is related to their medical history, and then 5% is their personal information. And scary part, 3% was, data was actually wrong about their medication and prescriptions that they have. There's also a 3% error in terms of their lab test results. This is very, interesting, and it is scary to know that the system that we bring in still has errors that is like that, and that definitely would create a adverse event when the physician involved are making a decision of what to do with the patient itself. Another deep dive, and we go deeper into it, what are certain trends that we see that health IT has actually challenged and causes issues to our healthcare community when we use it? Medication errors is the top. Patient identification error, we see a lot. Laboratory resulted incidents, we see that plenty too, right? So these are some of the key trends that you really want to take note of as well. And diving deeper into that, we want to know, how does it all happen? What are some key contributing factors that we find that has resulted to those few key incident trends that we see related to health IT? We see data input, transfer, and output being a big problem, and that is because of the data quality. Poor data quality when inputting, system that transfers badly, that means information don't get transferred and don't get captured in time. The output display was not fantastic. A good example was the one that I gave, that the nursing information system does not display all the instructions that is given by the physician. That's an output issue. They show something, but they don't show everything. That has caused the nurse to make a wrong decision when they actually administer the medication again. So this has been one of the key contributing factors that we see. And system interoperability is related to transfer between the different system itself, different devices and sensors that are capturing those information. And when you want to use it real time from another system to the sort of database or electronic record, that has been a challenge itself. Sometimes when we are trying to pull out an MRI or an X-ray in the operating theater through the PAC system to the operating theater information system, so that doesn't work very well. Sometimes we pull wrong kind of X-rays and slides that has been on the screen, and that could have led to what we call wrong side surgery, and we've seen those incidents happen before. Other contributing factors are usability. I remember when health IT was actually being sort of promoted in the region, my friends, my doctor friends were really upset about it. We were sitting down and they were talking about how difficult it has been to use and they don't like it and stuff like that, right? The other problem was really the current people and the process that we have. I'm not saying that the clinical people are bad and the current process are bad. I'm just saying that when we adopt health IT, the team forgot to think about what is needed by the individual, particularly in training. The team forgot to think about that now that you have a new system, does the old process still work? Should we look at how we update that particular process when we deliver care to the patient itself? So those are things that we see, right? Diving another step deeper, and in the interest of time, I'm going to just rush through a bit more, right? Diving into this a little bit more deeper, research found that there were big challenges, right? 42% feels that by using a health IT system, it actually limits the effort to improve the workflow, as we need to improve the workflow because we have new protocols and procedure that we offer to patients. So therefore, there is a need to improve those workflow. 41% feels that I cannot change the model of care. So if I bring in a new technology, I want to change the model of care. The current process driven by the technology and the system itself has very limited opportunity for me to do that, right? So, and then the next one is the part that I feel it's something we have to take note. So people are over relying on the technology. So without this interoperability capability, they cannot do their job. They don't think they can improve care. So they rely very much on the technology that they have. So without this technology and the interoperability capability, they cannot do the job. And this is scary, actually, right? So we have to think about all this. So I won't go through all this sort of the more detail of the challenges that we face, but you can go through it from my slides. Later as well. Very quickly, more statistics when we dive into medication error. I'm going to do medication error. I'm going to do a bit more about patient safety very quickly. You can see the details here. The actual details about what CPOE has caused, dose admission, extra dose, wrong dose, overdose. So you can see the statistics that we have right here. And this is done in 2016. It's a bit dated, but I think it's important that we take note and on the areas where the system, which area of the system has actually caused harm related to medication error itself. Now on patient ID, so this is more on how the system has actually caused error in identifying a patient itself. I just want to highlight one of those things. People say they had a hard time trying to find patient medical record using the health IT system. This is something I wonder why, 68%. So this has caused a lot of problem in patient identification issue. So the survey or the study has shown that people find it very difficult to hunt for the patient's record. So take note of that. It's 68%. It's very high, right? So I'm just going to run through this as well. We have also cybersecurity issues that we talk about, and I think this need no more sort of explanation. All of us are very well aware that this has happened, this is happening, and it still becomes a big challenge. And like I say, you're using a lot of new nice system itself, but in the back end itself, there's a lot of complicated process that is involved, particularly in securing it. So I want to really run through the last couple of slides quickly, and it's very important because what should we do? We're now into this, some of us are already into this, so what should we do? Right, so here are some considerations without having to understand your individual hospital challenges because I'm not there. So here, there's just some of the considerations that I could actually just share with you guys so that you can have some thoughts to it. And if there's a time where already you have been using health IT for a long time, but maybe this is a time to take a pause and take a look and see whether this consideration has been thought through in the current system that you have right now. I'm just going to go through some of the key highlights, right? So intraoperability, look at how you are intra-operating between the medical devices, the systems, the clinical supporting tool, your electronic medical record, electronic health record. So those are the key areas you need to look at. Make sure you understand the user workflow, the usability. And we have already talked about the various dashboards or the interface that are challenging people itself. And this usability area is something that you have to think about. Remember the drawing that I showed you in terms of the framework of how people are looking at when they design the system itself. That is where a lot of consideration needs to be put in, and I urge that the team, and I say a team, not the IT team, but everyone else in this project team, think about and get involved. Finally, test again. Don't just run the system live because leadership says there's a deadline, I need to run the system live, But we really need to test and test. Design pilot testing projects. So ensure that you do more than one pilot testing project. Make sure that you're so confident in it before you roll it out, because once you roll it out and you change the processes on the front line, you're going to immediately create big changes in how your care are giving, especially if your hospital are a big hospital and you have a lot of patients. Build a learning healthcare system. We are never going to be perfect. We will never be able to build a perfect system. First, ladies and gentlemen, understand that. We are never going to be perfect when we build a system and adopt a system. We are never going to be 100% fantastic. But you need to build a learning system. And this learning system should have encompass range of all the criteria and a range of all the risk requirement that you need to monitor. So I'm calling that you become more proactive rather than reactive to the risk that we have to monitor, especially in adopting health IT. Knowing your risk versus today where you are solving the risk, it's a very big difference. So we got to really be in the area where we become more proactive, where we become more desired to understand the risk that is associated to all this technology and all this system integration that we bring into the healthcare environment itself. Then we can mitigate. So this feedback diagram that we created was really just a simple parameters of all things that we really need to do when we are monitoring a system that is already in place. And this framework structure is very simple. Everybody understands this structure itself. But the very challenging part is that how do we continuously monitor effectively? How do we identify risks? Identify risk proactively, not just reactively. Reactive means today you have a case. I know I have that issue. I learn next time in the future I will not repeat the problem. But this requires us to always have a case. My question is, why can't we have less of a case? Can we come to a position where we can mitigate them before it actually come to life? So some of the tools that you can use, these are just basic tools that you can use as well to identify your risk. It's the social technical model that you can adopt. Event reporting is so important. So today we are still learning from all these risks that we have, and we're also learning from the incident that we have. So event reporting system is so important. So these two combined will allow you to have sufficient ability to do some sort of analysis so that you can understand where your risks are in the implemented health IT system. So in conclusion, very quickly, health IT system demonstrates better healthcare outcomes. So a lot of article has talked about that. I agree to it. I love the use of health IT system, but we have to manage not just the IT risk itself, but also the inherent risk. We know in our healthcare facility and the care setting that we have, it has our own inherent risk. Now we are introducing additional new technology into the care setting itself. This will solve some of the problems and risks that we have, but it also brings in new risks. So the question is, do we know those new risks? If we do not know those new risks, how do we mitigate those risks itself? So when you're working on the system and designing a system, or now you want to relook at your own system itself, try to have more understanding on the design of the system. That little chart that I show you, all the arrow diagrams and stuff like that, how was that really designed? Is it appropriate? Is it workable for your current setting right now? And the other thing that, especially when I talk to hospitals that has already a system, here is the thought, and I've seen some people who have gone to the very far end. Many have started with patch. It's like your tire got punctured, you just put a patch. So a lot of symptomatic solutions has been designed so that you patch and patch and patch and patch when you see the coming problem. Sometimes all these patches has reached a certain stage where there's nothing, there's not got, the efficiency of this patching has caused more problem. And remember this, ladies and gentlemen, a lot of patching can cause new risk and new problem. Please take note, and I've seen some hospitals who have fall into that problem itself. And now the only way to get it out is to buy and use a completely new system by itself. So you're going to get into that issue. So you've got to think about how you want to work with that particular system. Have a robust plan, committed resources, not just money, but resources from the different team members as well. Comprehensive understanding of what the people need, the process that needs to be in place when you build in a new technology, and all the other new toys such as your sensors, your wearables, and all those things. Very much important to look into the detail of those technologies itself before you use. So what we're really calling for is to profile your risks. Profile all the risks that is related to health IT so that you can do a good plan to mitigate this risk itself, leading to a very good patient safety program. So once you have all that, again, this needs not any more introduction. Please make sure you have a monitoring program. Look at this all the time. I am slightly over my time. Thank you very much for spending time with me. I'm happy to take any question if you have. Thank you very much.
Anyone have any questions? I'm happy to sort of share more as well.
Dr. Chen, I think you have to unmute your mic.
Sorry. Okay. Thank you for Director Wu's excellent speech today. Actually, I learned much again from Director Wu. Actually, I have one question for Director Wu. I think it's not a surprise that the information technology will be applied in more and more fields of healthcare systems. So it is expected that we'll have new health IT-related patient safety issues in the near future. But I think so far, according to our experience, what kind of the IT-related patient safety issue is most difficult to prevent? And what kinds of the IT-related patient safety issues should be solved first because of the most adverse clinical consequence based on your experience? Thank you.
Thank you, Dr. Chen, for the question. So I think in the presentation, I mentioned some of the key, and so far what we have seen recorded ones are medication error. But I have a but. Sometimes the medication error is not because of just the system's problem. It is also other latent contributing factors, such as how we communicate and how we want that communication to. If the tool is designed to ensure that we comprehensively have thought through what to be communicated, then medication error can be minimized for sure, because that's the intention of CPOE system. The system itself is designed to minimize all this problem. The problem is, what are the criteria, the considerations, what are the elements that needs to be built into the system. For example, tall letterman for your medication, how do you write the medication names and stuff like that. The size of the font sometimes play a role. If the design of the system is very cluttered and you have many things on one screen, it makes it very difficult. Sometimes it's because you're clicking 3 times before you can reach to a certain point in a very busy environment such as the emergency department. That can be a challenge for the front line. So it is not so much because it is the user's fault or it is just the system's problem itself. What I want to highlight is that there are many latent contributing factors. We need to identify all these latent contributing factors, and when we are going to design it or we want to look at it to mitigate this, we can identify all these different factors and see which one has a bigger gap. So my suggestion, not just on medication error, but all the other things that you see as well from the incidents that have happened because of health IT, you should start looking at the design system and have a team of people to look at not the final outcome because the nurse make a mistake. Oh, because the system display a wrong name, because the doctor clicked the wrong thing. So that is not so much of an interest for us to find out so that we can patch, but it is more important for why did the doctor click the wrong thing or choose the wrong medication? Why did the nurse not read the instruction that is provided and supposedly provided? How did we identify the patient wrongly? Why is it so difficult to find the patient? So these are, I think, more pressing issues that we have to focus on so that we can truly deal with the various root cause. And it's just not one kind of root cause because there are latent contributing factors to this.
Thank you for Director Wu. I think your answer is quite important. I think maybe it's not the fault of the information technology. It is more the problem of the poor patient factor design. I think this is very important in considering the IT-related patient safety issues. We should consider all these things together to solve the problem. Thank you for Director Wu, and hoping that we can have invite you to give us more access speech in the near future. Thank you.
Thank you, Dr. Chen.
好，那下一个section 是由黄宏渊教授来去当我们这一段的 moderator， 然后他等一下会帮我们介绍苏国瑋教授。那苏教授是我们医疗人因工程的一个专家，所以刚刚那个Director Wu 其实也刚好提到这个很重要的这个人因工程的设计。那我们请黄宏渊教授来帮我们当开始下一个 section 的这个的主持人，谢谢。
Okay, thank you very much, Professor Chen. I'm Hong Yun Huang from Chang'an Memorial Hospital, and it's my great pleasure to introduce our next distinguished speaker, Professor Kuo-Wei Su. Professor Su get his master's degree in the Department of Statistics in National Central University, and he also got his PhD degree in Industrial Engineering and Engineering Management of National Tsinghua University. Professor Su has a very outstanding experience and also an expert in the field of AI and big data analysis, as well as the human ergonomics in medical practice. Right now, currently, Professor Su is a professor and chair in the Department of Information Management of National Kaohsiung University of Science and Technology. He also the convener of Human Factor and Design Program at NSTC. He also in charge of Laboratory for Human-Computer Interaction and Smart Technology. Today, he would like to share some of his experience in the field of smart medicine and artificial intelligence. So let's welcome Professor Su.
Dr. Huang, Ladies and gentlemen, good evening. Today, I'd like to talk to you about smart medicine, artificial intelligence, and human-computer interactions to echo ITPS theme. My name is Su Guo Wei. I'm currently a professor in the Department of IM at NKUST. Here you can see is my profile. I also serve as judge of Healthcare Quality Award for JCT, member in JCT Patient Safety Committee, and the convener of Healthcare Ergonomics Program in Healthcare System Consortium. Since 2019, I have had some judge activities and speech related to medical human factors, as well as the projects from National Science and Technology Council and the industrial in Taiwan. Firstly, let's see smart medicine and artificial intelligence. In the past 2 years, I have been honored to be invited to serve as a human factors expert in the final field judge of Smart Medical Awards. We have seen many innovative topics, most of which are smart technology and information platforms. Among them, the application of AI-assisted decision-making has attracted much attention. Could you please think about what is the key to success for those innovative smart technology and information platforms? Let's take a look at the smart medical judge items highlighted in red fonts. We can confirm that the smart medical care is user-oriented as the starting point. Among them, the use of design thinking and the user experience design is the most important. Now, I'd like to respond to the key to success for the innovative smart technology and the information platform. The answer and the most important thing are about creating value for that person. Creating value for that person, you may implement a user-centered approach. The starting point for innovative thinking is to clarify who you want to smile and to understand the user with simulate and observe ways. How to do? Firstly, to confirm who needs service and respond to their preferences and habits. Secondly, to optimize user interface and the user experience. Finally, constant testing and correction and feedback. Here we can see the similar definition about smart medicine from WHO and FDA. The four most commonly used directions of smart medicine are diagnosis, monitor, treatment, and prevention, and the 6 technology are ABCDEF, and even metaverse. What I want to emphasize here is that human factors engineering should be included in this definition of smart medicine. We haven't really entered the metaverse yet. Can you distinguish VR, AR, and MR? Through the AR head-on display, the anesthesiologist in the operating room can understand the status of multiple patients with free heads, such as patient vitals and alarm for 6 operating rooms, and the single patient details for a single operating room. This is an example of laparoscopy with AR adaptations. It can improve the discomfort and the fatigue faced by doctors in the past during surgery. The doctor wears the HMD Meta 2 to combine the stare and the movement of the foot to perform surgery. A wireless optical mouse is embedded in the rubber clogs, which rotates through the heel to allow doctors to switch between patient image. The system combines a think-aloud protocol, a system usability scale, and a NASA task load index to evaluate its usefulness and usability. Let's move on to see the human-computer interaction of MR in surgery. This study surveys on 13 orthopedic surgeons wearing an MR headset. Overall, surgeons were satisfied with the application of this novel technology, but several concerns should be improved. The device size and the weight rating can affect wear comfort and time. Voice command and gesture function were less favorably graded. Hologram is helpful for the user's understanding, but it may also cause perceptual conflicts. Next is the application of AI, namely preliminary diagnosis and the prediction and the medical image diagnosis. But AI is also imperfect, with reports that IBM Watson Health often provides inaccurate medical advice, prescribes the wrong medication to patients, and many physicians point out that the system has not delivered significant benefits. Google Health seems to have a problem. AI can identify signs of diabetic retinopathy from an eye scan with more than 90% accuracy from lab. The accuracy is high in the experimental environment, but very different from the real environment. The current risks of AI are non-transparent, cyber attacks, and the system. Under the risk of non-transparent, it also highlights the importance of explainable AI, XAI, which can be enhanced in the future with new MLP, explainable modes, and the explainable interface to enhance the interaction between AI and the human intelligence. This case study provided a first set of user requirements and the design patterns for an explainable decision support system in medical diagnosis, showing how to involve experts and the users in the development process and how to develop more or less generic solutions for general design problems in XAI. The approach consists of 3 components: domain analysis, requirements elicitation and assessment, and finally, multi-model interaction design and evaluation. This is an example for CDSS UI design. Here you can see is preliminary design of user interface through user research to gather user feedback and then improve. This plot shows improvements based on the feedback from heuristic evaluation. The new version adds high-risk explanations and suggestions, add more information on patients, and integrated with EMR records. The study also adapts prioritization, grid, and the service blueprint to gain insight into what workflows are in the patient journey, what must be prioritized, and what the needs of healthcare workers. Further improvements are made according to the two figures. And finally, the third generation interface is This is the third generation of the user interface from 8 users' feedback. Here are design considerations. It aids feedback mechanism. Ask physicians, do you agree with this? And aid patient performance score. Next is ergonomics and here you can see medical and healthcare is the one research focus in Taiwan ergonomics. Human factors engineering is human-centered design. The medical design must be properly evaluated from the user, the environment, and the medical device before it can be considered safe, convenient, and effective by the user, thereby reducing the risk of illness. Human factors engineering can bring the following benefits to healthcare. For example, improve clinician performance, enhance patient family-centered care, and so on. What is the ergonomics? And you can see the graphic. Can you remember which one turns on the air conditioner and which one destroys the world? Of course, it's a bad design of man-machine interface. This graphic highlights the importance of human factor design. From here, you can see the relationship of human factors in healthcare and patient safety. For example, cognitive ergonomics concerns mental workload, decision-making, human-computer interaction, and so on. How to produce a design that meets user needs. To apply human factors engineering, start with the easier to understand design thinking. Design thinking is a human-centered approach to innovation that draws from the designer's toolkit to integrate the needs of people, the possibility of technology, and the requirements for business success. The plot shows 5 steps of design thinking: emphasize, define, ideal, prototype, and here I'd like to emphasize the importance of design. The first one is persuasive design. We cannot directly give products or systems that meet high-level goals in people's lives or works. To achieve higher life goals, people must take new actions on their own. So it may be possible to convince people to act to achieve their own life goal through design. That is behavior triggers. Design method is universal design. Universal design is the design and the composition of an environment so that it can be accessed, understood, and used to the greatest extent possible by all people regardless of the age, size, ability, or disability. An environment should be designed to meet the needs of all people who wish to use it. The plot shows the 7 design principles. Here is a study about the user-centered design for developing e-health system. E-health system needs to consider the requirements from user-centered for every kind of user, such as patient, caregiver, clinician, and the nurse. The system designer can invite users to participate in the design process to design the UI system and function to improve usability and accessibility. The plots are web and app for digital patients and caregivers. We can provide a friendly interface with some elements that ease to navigate and according to user preferences and needs to design UI and functions. These plots are web and app for healthcare professionals that can provide a simple and clear UI for easy to manage patient consultation information and modify the care. To be summarized, a good human-computer interaction design is to consider user cognition, scenario of use, and follow the design thinking process, especially through the human-computer interaction design method. The use of smart technology in medical care can be improved, and the goal of the smart medicine can be truly implemented, reducing the risk of patients. Thanks for your listening. Bye.
Okay, thank you very much, Professor Su. Give us a very comprehensive talk regarding the smart medicine and AI application for healthcare prevention for patient safety and increasing the medical quality. I wonder, is there any comment or question on the line? Professor Su, are you on the line? Okay, I'm sorry. Professor Su seems to be he'll be offline right now. But I think that from Professor Su's talk, I think he gave us a very comprehensive, fruitful talk regarding a smart medicine and AI. And we can recognize following the technological advancement and the healthcare schemes integrating AI has become increasingly prevalent. I think the AI algorithm may be identify lesions and disease that are difficult for healthcare professionals to detect manually. So I think this effectively facilitates diagnosis and treatment procedure. In the future, probably we can use AI to enhance our medical quality and reduce some error for the patient safety. Okay, so because the time is limit, we are going to move to our next session for the discussion. And I would like to introduce the session of our next session, the moderator, Professor Kuo-Ping Chong. And Professor Chong right now is a vice superintendent of Chinese Medical University. and he also the chairman of Academic Research and Developmental Committee of THQA. So let's welcome Professor Chong.
钟教授，你麦克风没有开 ，Please turn on your audio.
钟教授，你的 speaker。
Thank speaker.
Okay, now. Okay.
Thank you for Dr. He Huang introduction. I'm Guo Pingjiong from Zhongshan Medical University Hospital. I'm pleasure in join the discussion session because time limit. It's so late, so I'm only for one question to specialists, Dr. Chen and Dr. Guo. What's your suggestion? According to your previous experience about Taiwan IT and health safety, Dr. Guo.
Yeah, thank you, Dr. Zhong, for asking the questions. And before I start to share my thought about the implementation of IT in Taiwan, I would like to thank Mr. Wu again for the inspiring talk and the reflection on the unintended consequences of IT implementation. And I believe most of you have the experience that we keep hearing that physicians in Taiwan are fatigued with the message popping up on their computers. I'm not sure whether Mr. Wu has similar story in Malaysia. And I think it's quite common here, the healthcare professionals may just ignore the advice or even warnings from IT systems because they think the suggestions from the systems are not the most optimal choice for their patients and not comply with their clinical experiences, or even not being subjected to guideline recommended care. And some of these disappointing scenarios are just caused by the fact that there are not sufficient resources, which including leadership, staff, time, and the right tools to develop a reliable IT system and have it entirely tested before getting online. I believe that the lack of safety culture for implementing IT systems might be a challenge for healthcare providers in an age where IT plays a more and more critical role in delivering health care. And if there is still a chance, I would like to hear from Mr. Wu his experience and suggestion that is there any advice to tackle this problem at the higher management level, especially how to build a culture for safe and effective IT implementation? Thank you.
So I'm going to do a quick.
Thank you for Professor Guo and Dr.
Chen.
Chen.
Hello.
Professor
Yes, I'm
Chen,
here. I'm on the line.
Your suggestion?
No, I don't think I have any suggestion about Taiwan IT and safety, but I view the Professor Su here talk about something about AI assistant clinical decision on COVID-19. I think it's a very interesting issue. I don't know if somebody have the same experience. Since medicine is an art, do you think about there's any possible benefit of AI on COVID-19? I think sure, but they also have some possible harm for AI or HIT. You know, during the era of COVID-19, some doctors take care of the patient with the internet, with camera to visit the patient instead of visit directly. And there may be something wrong with this kind of thing because maybe some accident like a CPR may happen during that. And also I have lots of family. I talk with them with the video camera during the pandemic of COVID-19, and they didn't see the family, their patient. They just talk to me. But later, 3 days, 5 days later, they find they are different. And because the pandemic of the COVID-19 caused the interruption of family visit, I think it's also some harm for caused by the COVID-19. So I think, I don't know about your opinion about the COVID-19 era, the AI, the HIT. I think we still learn something from the COVID-19, and also we have do more advanced AI or HIT for the COVID-19. It's my comment.
Thank you for Dr. Chen as a comment. Because time limit, I will close this session and move next session. Next session, we're closing. Dr. Huang, please.
Thank you so much. How about Mr. Wu, Eric? Do you have any response to previous comment?
So very quickly to Sir Gao's comment. Actually, you are absolutely correct. And health IT is not the devil. The devil is what we put in the health IT. And a lot of times, like I said, and I think Professor Su has also shared the same opinion, whether you're using artificial intelligence or not, or are you just using an electronic medical record, or a simple CDS system that you have in the hospital itself. The main problem is we can never be able to predict all kind of scenario that the process in the hospital will be. We can never be able to predict all kind of scenario that a patient can be. So therefore, when we design this, we have to continuously look at what we need to monitor. And that is why I kept emphasizing that it is a continuous effort. If you are using an electronic record, like the question was asked whether we have seen any problems with those electronic records. Of course we have. We have seen people who actually press, and sometimes some hospitals that I've seen in Malaysia as well, they have created a system, and then because there was an error before, they always ask, are you sure you want to select this medication? Press yes. Are you sure this medication is meant for this patient? Press yes. Are you sure you wanted this to be dispensed at this time? Press yes. Everything is, are you sure? Are you sure? Are you sure? So some doctors will say, press 5 times yes, and then it will move. So the process has been ignored because there's too many what I call patches. You're just patching the problem, but you're not solving the root of the problem. We just continue to patch and patch and patch. So when you get used to it, even the nurse will say, Chinese will be like, 你按5次你就可以过了. So then there is no check and balance in the system. The system is actually being defeated because of the human nature of how we behave with the system itself, right? So this is not in Taiwan or in Malaysia. This is everywhere. Everyone who uses a system and you create patches like that, that is the main problem. So even artificial intelligence for COVID-19, prediction of certain kind of sort of category or patient level. If you put enough criteria in there, the AI can be able to predict it. The major problem is how do we know all the different variation of scenario that the patient has? For example, they have already existing heart problem. They have diabetic problems, things like that. So we've got to add a lot of those things in there. And then again, you have also the culture of compliance from the patient itself. Will they tell you everything that they have? Or will they not tell you everything that they have? So these are going to make your prediction model a little bit different. It is not the fault of the system. It is when we design it, we have to understand all these people, process, and technological challenges. And therefore, if we want to continue to evolve in using IT, which we cannot run away, moving forward, 没办法的, IT is going to be in our life. We have to accept it. And to be honest, 如果真的做得好好的话, that system is going to be fantastic. So therefore, I really think that we need to have that continuous monitoring program, continuous assessment to the tools that we have. Be very careful. Now, when we design tools, we also say that we will also identify the challenges and the risks. Why we cannot share this risk with the user? You already have a perfect system, but this is the risk that we monitor before we sell you the system. So when you are using the system, please also make sure that you also consider that potentially there is a risk that can come from this area where we were monitoring it when we develop the system before we launch it for the user to use. So with the same effort, we can simply turn what the manufacturer has been monitoring into reality, and it becomes our monitoring parameters so that we can monitor those risks of technology that is coming forward. This is what I'm saying, that we have to continuously monitor that way. Hopefully, we can minimize those incidents from happening. And I mentioned before, unfortunately, we cannot be 100% perfect. There isn't a way to be 100% perfect. Right. Sorry, and thank you so much.
Yeah, thank you.
Thank you so much for Eric. Today we have a very nice webinar. We have Eric and also Professor Su to share the experience about IT and the patient safety, and also thanks for Dr. Zhong and Dr. Chen and Dr. Guo and Dr. Huang for the excellent moderator, and welcome to to join our THQA and the JCT and also ASQUA webinar in the future. We have two more lecture in these 2 months. So please follow up our ASQUA and also THQA website. Thanks all for your coming. Thank you for tonight. Thanks again. Good night.
Night.
Good night. Thank you. Thank you all.
Good night.
Yeah.
Thank you.